Welcome to a new episode of NeoMed AI. Today we're diving deep into Neonatal Respiratory Distress Syndrome, RDS. It's a topic that, well, even for experienced neonatologists, keeps us on our toes, doesn't it?
It absolutely does. It's common, but the management can get complex.
So, our mission in this deep dive is to take a really comprehensive look. We'll start with the basics, the core concepts, then move into day-to-day management, and finally tackle those really challenging advanced cases.
Exactly. We'll be leaning heavily on national guidelines, high-quality evidence, aiming for that clinically applicable knowledge because the field is changing.
And even for experts revisiting fundamentals and exploring the nuances, you often pick up new insights, right? Reinforce best practices.
Couldn't agree more. Staying sharp is crucial for these tiny patients.
Okay, let's unpack this then. We're starting with a classic case scenario, sort of ground zero for our discussion.
It sounds good.
Imagine this. You're at an emergency C-section. Baby's born at 27 plus 4 weeks. Mum had preeclampsia and got a partial course of antenatal steroids, maybe just 18 hours ago.
Okay, partial dose. Noted.
At birth, you see it all: subcostal, intercostal retractions, that expiratory grunting, nasal flaring, and maybe go straight on to CPAP initial FiO2 35%.
Right.
So for you, listening, what's running through your mind? What are the differentials? But what's the most likely diagnosis? And fundamentally, what's going on?
Well, with that picture, less than 28 weeks, classic distress signs, right away, needing oxygen. Neonatal RDS is, overwhelmingly the top diagnosis.
And the underlying issue?
It's that primary deficiency of pulmonary surfactant. The lungs are just too immature. Without enough surfactant to reduce surface tension in the alveoli, they collapse.
Leading to atelectasis.
Exactly. Atelectasis, stiff lungs, low compliance, and that classic VQ mismatch makes the baby work really hard to breathe. And at 27 weeks, it's incredibly common. UK figures suggest 80–90%.
Yeah, a huge percentage. And that partial steroid course, how did that play into it?
It's significant. Antenatal corticosteroids, betamethasone, dexamethasone, they work by stimulating surfactant production and release. A complete course, usually given more than 24 hours before birth, gives the best effect.
So, a partial course means
It means some benefit, certainly better than none, but maybe not enough to fully mature the lungs. So you might expect slightly more severe RDS or maybe a less dramatic response to initial CPAP. It just raises your index of suspicion a bit.
got it. And the CPAP itself, we put them on it immediately. Why is that so crucial beyond just keeping the airways open? Right now,
Early CPAP is absolutely fundamental. It's not just about immediate support. It establishes functional residual capacity, the FRC, by providing that continuous distending pressure. This prevents further alveolar collapse, reduces the work of breathing.
and crucially protects the lung long term.
Precisely, it minimizes the need for invasive ventilation, which carries its own risk of lung injury. UK, European guidelines, they all strongly recommend CPAP right from the delivery room to try and reduce that downstream risk of BPD.
Okay, and that starting FiO2 of 35% on CPAP, is that a particular trigger point?
It is that figure 35%, or really anything consistently above 30% on adequate CPAP, is a key threshold. It signals moderate to severe RDS and tells you that surfactant replacement therapy needs to be strongly considered, probably sooner rather than later.
Even though RDS is most likely, we should quickly think about other things.
Always. Briefly consider TN, though much less likely this premature. Pneumonia or sepsis is always a possibility, especially with an emergency delivery, and a pneumothorax, though usually that's a complication rather than the initial problem.
And the chest x ray, we often get one, but how vital is it for that initial decision?
The classic findings are low lungs volume, diffuse ground glass appearance, air bronchogram, but, and this is a key pearl, you shouldn't delay treatment waiting for an X-ray if the clinical picture is clear. Treat the baby, not the film.
Makes sense. And what about caffeine? When does that come in?
Early. Standard practice now for all babies under 30 weeks. It's a respiratory stimulant. Helps reduce apnea, but importantly, evidence shows it helps reduce BPD and gets babies off ventilation sooner. It's a simple, effective intervention.
So, pulling this all together, how do you explain this complex situation to worried parents at the bedside?
You need clarity, empathy, and honesty. I usually say something like, your baby arrived very early and their lungs aren't quite ready to breathe easily on their own. This is very common for babies born at this stage. It's called respiratory distress syndrome.
Focusing on the immaturity.
Yes, it means the tiny air sacs in their lungs are a bit stiff. We've started them on some gentle breathing support called CPAP to help them, and we're giving extra oxygen. Then, if surfactant is likely, there's also a natural substance, like the one their lungs are short of, that we can give them directly into their lungs to help make breathing much easier.
And managing expectations.
Crucial mention that with modern care survival is very good, but also be upfront about the potential challenges ahead, like needing breathing support for a while or the risk of longer-term issues like BPD. Keep the communication open.
Okay, that sets the stage perfectly. Let's move the case forward. Our infant is now 2 hours old. Things aren't improving. Work of breathing is worse. They're on CPAP PEEP of 7, but the FiO2 has climbed to 45%.
Okay, definitely worsening.
Just X-ray confirms severe RDS. You got a blood gas, pH 7.28, PCO 27.5, PO2 8.1, base excess -4. What's the immediate next step? And what are you thinking regarding surfactant?
Right. This is a clear failure of initial CPAP support. The immediate step is surfactant replacement therapy. No question. The climbing FiO2 and worsening distress. It's time.
And how do you give it?
The decision is how if the team is skilled, and importantly, the baby is still spontaneously breathing reasonably well, despite the distress. Minimally invasive surfactant administration, MISA or LISA or MIST, depending on your local term, is often preferred
Why Lisa?
because the evidence is strong now. It reduces the combined outcome of death or BPD and cuts down on mechanical ventilation compared to the traditional intubate surfactant extubate or INSURE method.
But if Lisa isn't an option or fails,
Then INSURE is the fallback. You intubate quickly, give the surfactant, and aim to extubate back to CPAP or NIPV as soon as possible, ideally within the hour.
and the surfactant itself, dose and type?
Natural animal-derived surfactants are definitely superior to the older synthetic ones. In the UK, we commonly use CuroSurf, usually at an initial dose of 200 milligrams per kilogram.
You mentioned Lisa needs skills. What's the main challenge?
The main challenge is doing it effectively without destabilizing the baby. You're passing a thin catheter while they're on CPAP. They need to keep breathing spontaneously. It requires good technique, teamwork, and practice. If the baby is becoming apneic or bradycardic, you might need to abandon Lisa and go for INSURE.
And for INSURE, any pre-medication needed for that brief intubation.
Yes, generally to make it quick, smooth, and less traumatic, pre-medication with analgesia like fentanyl and sometimes a short-acting muscle relaxant like suxamethonium, is often used. The goal is rapid sequence intubation.
During that short ventilation period in INSURE, what settings are crucial?
Lung protection is key even for a short time. Volume-targeted ventilation, VTV if available, is ideal. Aim for tidal volumes, around 4 to 6 milliliter per kilogram, and appropriate PEEP, maybe 5 to 6, just enough to support oxygenation and surfactant distribution without causing injury.
Okay, surfactant is in. Now, perhaps the most crucial immediate post-surfactant action. What happens when that FiO2 plummets, say down to 21% rapidly?
The absolute most critical thing is to wean the FiO2 aggressively, immediately. Surfactant works fast. Lung compliance improves dramatically. And if you don't pull back the oxygen, you will make the baby hyperoxic.
And the risks of hyperoxia?
Big risks: retinopathy of prematurity ROP, oxidative lung injury contributing to BPD. So chase that SATs down to the target range, which for this gestation is typically 91 to 95%. Don't be afraid to turn the oxygen down quickly.
What about a second dose? When would you consider that?
You'd consider a second dose if the baby shows signs of recurring RDS, usually needing FiO2 backup above 30% or more with persistent distress, typically 6 to 12 hours after the first dose. The evidence for second or subsequent doses isn't quite as strong as for the first, but it's definitely indicated if there's clear, ongoing surfactant deficiency.
Shifting gears slightly, what about fluids and nutrition in these early stages?
Vitally important, but needs careful handling. Fluid restriction is generally to the rule, maybe starting around 60 to 80 ml a day. Too much fluid can worsen pulmonary edema, especially if there is PDA.
And feeding?
Early parental nutrition is crucial. Amino acids and lipids ideally started within the first 24 hours to provide calories, and protein prevent catabolism and support growth.
Going back to that initial gas PCO2 7.5 kilopascals and pH 7.28, is that CO2 level okay?
Actually, yes, that falls within the range of permissive hypercapnia. We tolerate slightly higher CO2 levels, say up to 8 kilopascals, as long as the pH stays above about 7.22. It's a lung protective strategy. Avoids aggressive ventilation just to normalize the CO2.
It's fascinating how much global agreement there is on some things, but differences remain. How does UK practice compare internationally on these points?
Yeah, there's strong consensus on early CPAP worldwide. Surfactant thresholds that FiO2 around 30% are pretty similar too. LISA administration, that's where it varies a bit more. Europe seems most directive about using LISA. In the UK and US, it's becoming more common. Definitely trending that way, but maybe still more variable unit, depending on local expertise. Volume-targeted ventilation is pretty much the global standard if intubated.
And postnatal steroids for early RDS.
Big consensus against routine early use internationally, mainly due to the neurodevelopmental worries. Cautious selective use for evolving BPD later on is common, but the protocols differ significantly place to place.
Thinking about practical wisdom, what are some key pearls or common pitfalls in managing RDS?
A huge pearl: trust your clinical judgment. If the baby looks like they have RDS and needs support, don't get hung up, waiting for the perfect X-ray. Another pearl: anticipate that post-surfactant improvement and be ready to wean oxygen fast.
And pitfalls?
A common pitfall is using too low CPAP pressure initially. These babies often need 6, 7, even 8 centimeters to overcome the atelectasis. Don't start at 5 and wait. Another big one is delaying surfactant when it's clearly needed. That watchful waiting can be detrimental.
Anything else?
For Lisa, gentle, steady administration is key to avoid reflux or bradycardia. And don't forget the supportive care. Temperature, fluids, nutrition, they're just as important as the respiratory support. Oh, and if a baby deteriorates after surfactant, don't just assume it's RDS worsening. Think pneumothorax. Think PDA.
That's a great point. It leads us nicely into the really tough situations. Let's make our case more complex. The infant is now 36 hours old. They've had 2 doses of surfactant. Despite that, they needed reintubation and are now on volume-targeted ventilation. Settings are high: FiO2 70%, PEEP 8, PIP 26, blood gas pH 7.25, PCO2 8.5 kilopascals, and echo shows a moderate to large PDA with left to right shunting and signs of pulmonary hypertension.
Okay, this is a very sick baby. Definitely refractory RDS territory.
How do we formally define refractory RDS in this kind of context? What are the main culprits we need to investigate now?
Refractory RDS basically means the baby isn't responding as expected to standard therapy, like 1 or 2 doses of surfactant and appropriate support. They have persistent high oxygen requirements or ventilation needs. In this case, the top things to investigate are one that hemodynamically significant PDA. A large shunt floods the lungs, causing pulmonary edema that looks like worsening RDS. It's the wet lung confounding things. 2. The pulmonary hypertension. Is it secondary to the severe lung disease or something else? It causes right-to-left shunting, worsening hypoxemia. 3. Although rare, you have to consider congenital surfactant protein deficiencies, genetic problems where exogenous surfactant just doesn't work properly. And 4. Underlying or superimposed severe sepsis or pneumonia. And infection can inactivate surfactant and cause an ARDS-like picture.
Given the confirm of pulmonary hypertension, what advanced therapies might be on the table, like inhaled nitric oxide?
Inhaled nitric oxide comes up. It's a selective pulmonary vasodilator, but for preterms, the evidence isn't great.
Not like in terms babies with PPHN.
Exactly. For preterms, Cochrane reviews show it doesn't significantly cut mortality or BPD. It might give a temporary pump in oxygenation sometimes, but it's generally reserved as a rescue therapy specifically for confirmed pulmonary hypertension with right-to-left shunting after you've optimized ventilation completely. It's not a routine go-to.
This is definitely where the rubber meets the road. Niche topics, controversies. Let's tackle that PDA first. How do you manage that in this critically ill infant?
Hugely controversial area. The pendulum has really swung towards conservative management. Many PDAs in preterms close on their own, so first steps are often fluid restriction, maybe diuretics, optimizing PEEP to reduce left-to-right shunting.
And medical or surgical closure.
That's reserved for cases where the PDA is clearly causing significant problems like preventing weaning from the ventilator or causing systemic hypoperfusion. Medical treatment with ibuprofen or indomethacin is common, but large trials haven't consistently shown they improve major outcomes like death or BPD. Surgery is usually a last resort. It's a real case-by-case decision, often with lots of debate.
Okay, and that PCO2 rose of 8.5 kilopascals with the pH dipping to 7.25. Is that still acceptable permissive hypercapnia?
It's pushing the boundary. Permissive hypercapnia is usually tolerated if the pH is above 7.22. At 7.25, you're watching it very closely. If the acidosis worsens, you need to improve ventilation, maybe increase the respiratory rate or the tidal volume slightly if on VTV. Or this might be a situation where you consider high-frequency oscillatory ventilation. HFOV,
HFOV is a rescue.
yes, HFOV can sometimes improve CO2 removal more effectively than conventional ventilation at high pressures, while potentially being gentler on the lungs by using very small tidal volumes at a high frequency. It maintains lung recruitment with a constant mean airway pressure. It's not proven superior overall to modern VTV, so it remains a rescue strategy.
What about revisiting postnatal corticosteroids now in this truly refractory situation?
This is ethically and clinically very challenging. Early steroids less than 7 days for RDS failure. Most guidelines advise strongly against it due to the neurodevelopmental risks, particularly cerebral palsy.
And how seriously are you considering genetic surfactant issues now?
With 2 doses given and such a poor response, especially if the initial response was minimal or transient, you definitely have a higher suspicion. Key genetic defects involve proteins like SFTPB, SFTPC, or the transporter ABCA3. You'd likely discuss sending genetic tests, usually coordinated with a specialist center.
Could trying a different type of surfactant help?
Probably not. If it's refractory RDS due to severity or complications like PDA, PPHN, switching between natural surfactants is unlikely to make a difference. And if it's a genetic deficiency, no exogenous surfactant will work properly.
Is this classic RDS, or are we now talking about neonatal ARDS?
Good question. Classic RDS is primary surfactant deficiency. NARDS, Neonatal Acute Respiratory Distress Syndrome, is more about inflammatory lung injury, often triggered by sepsis, meconium aspiration, etc. In severe prolonged RDS like this, the lines can blur. Significant lung injury and inflammation can develop, creating an ARDS-like picture on top of the primary RDS. Management remains largely supportive and long protective.
ECMO isn't an option for this 27-weeker?
No, unfortunately not. Standard criteria usually exclude babies under 34 weeks or less than 2 kilograms due to the unacceptably high risk of brain bleeds, intracranial hemorrhage.
What about that newer strategy adding budesonide to the surfactant? Could that have been tried or would be considered now?
That's a rapidly evolving area. Large trials like Neurosis showed that giving budesonide mixed with surfactant reduces death, or BPD, significantly. It's usually given with the first dose prophylactically in very high-risk infants. Could it be considered as a rescue? Less evidence for that specific scenario, but its use is increasing and local guidelines might address it. It's definitely promising.
Looking globally again, how do approaches differ in these really complex preterm scenarios?
For refractory hypoxemia, HFOV is a universal rescue strategy. Nitric oxide use is generally cautious everywhere. For preterms, maybe slightly more liberal rescue use in some US centers compared to Europe, which strongly always advises against routine use.
PDA and steroids.
PDA management sees a global trend to conservatism, but huge practice variation remains. Rescue steroids for BPD prevention or refractory failure are used cautiously worldwide, with ongoing concern about side effects dictating highly selective use and varying protocols. The surfactant budesonide mix is gaining traction globally as the evidence builds.
This has been incredibly comprehensive, connecting the dots from the basics right through to these consultant-level dilemmas. Now, for you listening, let's try to apply some of this. Here's a quick scenario. A 29 plus 6-week infant, full antenatal steroids. At 5 minutes, they're grunting on CPAP. FiO2 rose to 25%. Immediate next steps.
Okay, 29 plus 6 full steroids, FiO2 is only 25%. Immediate steps are continue CPAP. Monitor closely. That FiO2 is below the usual threshold for surfactant. You'd get IV access. Start caffeine. Keep them warm. Observe the trend. Be ready to intervene if the FiO2 starts climbing or work of breathing increases. But don't jump to surfactant just yet. Patience, but vigilance.
Okay, makes sense. Now, for a much tougher one, reflecting the complexity we just discussed, you have a 24-weeker. It's day 2. They're on HFOV for a refractory RDS, despite 2 surfactant doses. FiO2 rose and is stuck at 85%. MAP is 16. Echo confirmed severe pulmonary hypertension with right-to-left shunt. You tried INO and got a brief flicker of improvement, but it wasn't sustained. What's the discussion now?
Right. This is a grim situation. The discussion has several layers. First, the INO, given the lack of sustained response and poor preterm evidence, you seriously discuss stopping it. Second, optimize HFOV. Ensure MAP and frequency are appropriate. Third, actively investigate underlying causes. Has genetic testing been sent? Could there be an underlying infection? But perhaps most importantly now, you need to initiate honest, compassionate discussions with the parents about the prognosis and goals of care. Given the severity, lack of response, and extreme prematurity, you have to explore the possibility of redirecting care towards comfort. If that aligns with the parents' values and the clinical reality, it's about shared decision-making in the face of profound uncertainty and likely poor outcome.
That really highlights the weight of these decisions. It's about evidence, nuance, but ultimately individual patient care and family communication. Looking ahead, what are the big unanswered questions or research gaps in RDS?
Oh, plenty. We still need to define the truly optimal non-invasive support strategies, modes, interfaces, pressures. PDA management is crying out for definitive trials to tell us who actually benefits from intervention.
And the
Budesonide,
surfactant mix?
crucial long-term neurodevelopmental follow-up is needed for those babies. We also need a better standardized definition of refractory RDS for research and lung ultrasound. It's emerging rapidly, but needs more validation for routine use in guiding therapy.
Well, that was an incredibly thorough journey through neonatal RDS. So much to think about, even for those of us who deal with it daily.
Absolutely. If I had to boil it down to 3 take-home messages for everyone listening, they'd be: 1, early appropriate, non-invasive support, usually CPAP, plus timely surfactant using lung protective strategies like LISA, where possible, remains the absolute foundation. 2, when RDS is refractory, think broad. Investigate PDA, pulmonary hypertension, consider infection, and don't forget rare genetic causes. It requires a systematic approach. And 3, keep learning. The field is moving fast. We need to critically evaluate new evidence and adapt our practice.
Great summary, and maybe a final thought to leave everyone with. As neonatal care advances and we save even smaller babies, how do we navigate the really difficult ethical terrain? Balancing the drive to use every available tool against the potential for significant long-term morbidity, especially in these incredibly complex refractory RDS cases. Something to ponder. Thank you so much for joining us on this deep dive. Please do check out the source materials for even more detail.
And just a reminder, this AI-generated information is intended for educational purposes only, serving as an educational tool for trained and practicing neonatal clinicians. While generated with care, it may not be 100%. Clinicians must always apply independent clinical judgment and cross-reference with the most current national and local pipelines.